On the spine and sacroiliac joint, and we'll start with just going through some of the general components following your outline. So the first one is, when we talk about the spine and sacroiliac joint, is to remember that we treat it essentially the same as we do the other joints. So it can sometimes seem overwhelming because there's so many facet joints, and it's hard to get in and palpate, and we don't have a lot of specific special tests, but we're going to treat it just like any other joint as far as rehab. So the first thing when we talk about program components is to use modalities and manual techniques to try to decrease pain. There's a difference between hypomobile and hypermobile segments, and we'll get a chance to experience this in lab on each other, but typically when a person is laying prone and you're doing posterior anterior mobilizations, you can feel a difference between how much give there is in different areas of the spine. Typically you have more hypermobility in the lumbar spine and hypomobility in the thoracic spine, but it should be assessed prior to any mobilization. Flexibility exercises will be prescribed based on posture done in the back evaluation. You might also have to include posture correction, teaching pelvic neutral. We talked about this in class one day when we were going through core. Back stabilization exercises, and again, this is primarily core activities, so we'll be doing high reps with low loads or low stress. So generally we start with dead bugs. Good body mechanics as far as lifting and moving, sitting. Strength, again, prescription will be based on the posture eval and what we found there. Usually the abs and the glutes are weak, and those will be ones that are focused on. So agility and coordination and then cardiovascular also continue to be part of the program at the end phases of rehab. It's interesting to note, though, that most low back pain in athletes should resolve in 6 to 8 weeks, regardless of treatment. And so you can pretty much do anything other than, they say, complete rest is not helpful, and you should see some improvement. So, as we look at the spine, we're reminded that we have 3 sections: cervical, thoracic, and lumbar. We have discs between each vertebral body, and then the bony connection from one vertebrae to the other is a facet joint. We've got 2 facet joints on each side. As we take a look at the sacroiliac joint, we can see that, again, we have 2 of them. The shape of the joint is such that it's kind of wedged in there, and there's a lot of ligamentous support. However, this changes from person to person, and even a slight rotation between the sacrum and the ilium can cause some lower extremity discomfort or predispose somebody to problems. So, moving on to rehab techniques in regards to flexibility, typically the stretches will be held 15 to 20 seconds and repeated 4 to 5 times. We're going to really watch for incorrect or substitution patterns during the prescription of exercises. I know in the book that the author really likes to do a lot of soft tissue massage, so I've just shown a few in this PowerPoint of ones that I've used that I found were particularly helpful. People with headaches, oftentimes I'll do a trigger point release for the posterior cervical muscles. So I just have the hands cupped underneath the occiput, the fingertips just off the edge of the occipital bone, and pushing in or in an anterior direction up to the ceiling to do a trigger point release in the suboccipital area. And I'll typically hold that for 20 to 30 seconds and go through maybe 6 to 8 repetitions. Another stretch, this is a great stretch for the upper trapezius, especially if his left or his right arm is anchored down, if you were holding on to the table just to anchor himself and then was leaning into the left. You can see his head is rotated and flex forward towards his opposite his opposite shoulder, which is a better stretch than if he would just do a side bend for the upper trap. This is oftentimes another one used. Somebody's having rhomboid or middle trap pain or trigger points. We'll tape 2 tennis balls together and somebody can do a self-mobilization. All right, going back to our sheet, we'll go through some of these exercises. This is cervical retraction, used frequently with somebody that has radiating pain down into their arm. So we'll have them go into retraction and hold for a few seconds. They might come forward into protraction or just into neutral. Cervical flexion with just a little bit of overpressure, not commonly used. Here's a couple different upper trapezius stretches. If you're able to try those now, that'd be a good idea, and just see how, if a side bend stretches the trap more, or if you actually had this patient look more towards his armpit rather than straight ahead, so we get some rotation, you should get a little better stretch with this. Scalene stretch, again, we have 3 parts of the scalene. This is why you see 3 different positions. These are muscles that run down just the side, lateral side of the neck. So we're getting posterior scalene, middle scalene, and anterior scalene in these pictures. I think it's best if you go into cervical retraction and then a side bend before you try to do these exercises to get the greatest effect. Here's an option for stretching through the pectoralis muscle. You could go up to a door frame or a corner or a wall. A lat stretch. Make sure that the arm comes up into flexion. You can also, in this picture, if he put his elbows on a countertop and leaned forward so his head came down between his arms, that's a good lat stretch. I see on our notes that I missed pec minor stretch. A pec minor stretch, I don't have a picture of this, but a good one is when you have somebody lay supine and they have a towel roll running down the spine, just that direction. They lay with their arms at their sides, and then they need somebody to come in and actually push their shoulders posterior. Again, they're in a supine position, so if they push their shoulders posterior, should get a stretch in the pec minor. Remember that attaches to the coracoid process and the sternum. So you need to be more concerned about where that coracoid process is going. It needs to come back or posterior to get a stretch. Prolonged side bend stretch, maybe an option. Putting a pillow roll under here, maybe a couple more. This is especially effective if we have some facet impingement. We'll come back to this stretch. It's more like a traction. So we're opening up the facet joints on the top side of the spine. Cat-cow stretch with her funky 70s outfit. So going into the cat, the cow then would be dropping the spine the other direction, so it kind of sinks down. If you want to get really fun with these, you get a freshman in and you tell them they have to add sound effects. It's kind of fun. A lumbar rock stretch, so they go into the cat position and then bring their hind end back towards their heels and do a stretch that way. You can also then return to that position and come forward into like a modified, if you're familiar with yoga at all, modified upward dog, or sometimes this is called extension of the spine, prone extension. And we'll be using these exercises in a particular protocol here. Prone on elbows, again, a commonly used exercise for a protocol with somebody that has radiating or discogenic pain. This is in the protocol that we'll discuss in the next PowerPoint. From that position, prone on elbows, they'll go into a press-up position where the arms are extended in front, pressing up. Everything from the waist down should be relaxed. And then they just work on bringing their hands closer to their body so they're right underneath the shoulders. Standing extension is another exercise that we'll be referring back to when we talk about working on an exercise program for a herniated disc. Lumbar flexion, of course, sometimes a stretch that we use. Knees to chest, you could do single knee to chest, you could do double knee to chest. Those are oftentimes used in rehab. Hamstring stretch, supine, to keep their back straight and into neutral position. And then we talked a little bit about this, a modified stretch for the rectus femoris. You could do a Thomas hip flexor stretch. If you pull that heel back, the heel that's hanging down here, pull it back towards the table, that really intensifies the stretch for this one. Quadratus lumborum. Quadratus lumborum is a muscle that runs on the backside from the iliac crest up to the lower lumbar vertebrae, and can often get tight with somebody that has prolonged sacroiliac or lower lumbar pathology. So here's a modified stretch. It works pretty good. She's stretching her right quadratus lumborum, I guess. As we move into joint mobilizations, we will work on, first of all, we need to assess and see how mobile they are. And one thing that you can do is just do a straight traction and see how much movement that you do get. We need to be gentle when we start with joint mobs of the cervical spine, and continually reassessing, asking the patient how they're doing with this. This is a fairly safe one, just straight traction, seeing if it relieves pain, takes pressure off of spinal nerve roots. PA stands for posterior anterior. So there's a pressure going from their posterior spine towards their anterior for the cervical spine. Now the facets are lined up straight such that in the cervical spine we don't go directly posterior to anterior. We come more at an angle, and that's shown in this picture with the arrow. So that's the direction of your push as we work maybe on one side of the spinous process, working on the transverse process, that area, and then we can go to the other side. It's not real helpful to do mobilizations right on top of the spinous process. They can be painful. So usually we're just off to the side, either way, trying to get more over the facet joints. Moving down the spine into the thoracic region, we can tell that we come, as we go lower, we're going to be more of a posterior anterior rather than a diagonal direction. And this is doing this posterior anteriors on one side. Hand position can be turned a little bit, and we can work more into the ribs as they connect into the vertebrae and moving the ribs. So we use the hypothenar eminence area and just do a posterior anterior mobilization. And typically if somebody has a rib that is hypomobile, that's fairly obvious. Because the segments, if you do this motion down in a different area or up in here, you get more, there's more give in the movement than in an area that's hypomobile or stuck. Some people just say it's stuck. And sometimes the PA mobs will be helpful. It's really helpful to add breathing to this. So the patient takes a deep breath, and then as they exhale, you move with them and push down with little oscillations down here at the end of their breath. They're just showing the direction of push in that picture. And we can do unilateral. Again, as we come down to the lumbar spine, we're definitely going straight down, no diagonal motion in this. So again, we don't have a concave convex rule that we follow with the lumbar spine. It's simply a posterior anterior direction, and we can go bilateral or unilateral. If we move on to self-mobilizations, there are a couple mobs that patients can do on their own. Here is a rib self-mobilization. So again, when we talk about the first rib, it's above the level of the clavicle. So she brings the towel, loops it around up top, and then she pulls this arm directly down to self-mobilize that first rib. We'll show another technique on how to do this in class, and you'll actually be able to feel the first rib and compare it, how much give we've got on one side compared to the other side. The other Self-mobilization is a lumbar positional mob. So the person lays in side line, the involved side is up, as on the top side. It's really helpful to put them in more side bend, so we would have a couple more pillows under here. So we try to open up the facets. This would be her left lumbar facets. And then if we move the hip into an anterior rotation and the shoulder into a posterior rotation, we've really opened up that facet joint. And taking hopefully pressure off of a spinal nerve root. This would be a home exercise that somebody would get, and they would lay there for maybe 5 or 10 minutes and to relieve pain down the lower extremity from the lumbar spine impingement. And after this, then they would certainly have some exercises that they would go into. So here's just the similar, the mobilization over now. She's giving some overpressure when this person is going into the stretch. We've talked about this. Hopefully you're really familiar with this strengthening exercise. Dead bugs with the arms. They also consider just with the legs is more difficult. Both is 3. So we numbered ours a little bit different, which is fine. It doesn't matter. Just as long as everybody's talking the same language as far as what's first level, second level, third level, or maybe you have to describe it. So I think we're well familiar with these. Cervical isometrics might be prescribed for somebody that has a lot of cervical muscular pain, and we're just trying to get some strengthening back. Typically, these people would be wearing a soft collar for these. On your notes, it says glute sets. We reviewed those in lab on Thursday. Extensor sets. I guess we kind of have a picture of this. So any muscle on the of the extensors of the spine, they could do an isometric. Here's an example of extensors of the cervical spine. Just pulling up and holding there for a count of 5 to 6 seconds. This can also be used as a progressive resistive exercise. That's what PREs means in your note, progressive resistive exercise, where she's doing repetitive cervical traction, so pulling back with just a pause and then forward and then back with just a pause. So against gravity is what's providing the resistance. I skipped ahead here, middle trap exercise and lower trap exercise, but I wanted to pull this picture up when I explain these. So this would be the position that the athlete would be in if they're working their middle traps. However, thumb position would be such that she should turn her hands so that her shoulders, so her thumbs are pointed straight up to the ceiling. And then squeeze the scapula together. That would be in the instructions. And that is a more true middle trap exercise. For the lower traps, the arms are brought into a little bit more abduction, so coming up at an angle, maybe instead of at 90 degrees, maybe more up at 130, 140 degrees. And then she would lift her arms up, again leading with the scapula, so we kind of have a back and down motion. This is a difficult exercise to do with any sort of weight, so it certainly wouldn't be done with weight. Again, the thumbs are in a position where they're pointing towards the ceiling for the middle trap, as well as moving into more abduction with thumbs up for the lower trap. All right, so prone flies. We're going to get more deltoid work with this position. Posterior pelvic tilt, we've talked about these, practicing them in positions of supine, kneeling, against the wall, standing. It can be a challenge sometimes to instruct someone on this if they don't know how to do it. Supine trunk curl. Typically the knees are bent, but we don't hook the feet under anything, otherwise we've turned the exercise into a hip flexor exercise. Abdominal crunch. On your exercise or your sheet that you have in front of you, your outline, I don't know that I put these on here as being called bowler exercise. Lots of times now people will refer to these as YWTs because you make well, if you see in this third picture, she looks like a big Y. If her arms were brought down to 90 degrees, she'd be a T, and she can also bend her elbows and make more kind of a W. But what she's doing is pushing the back of her hand into the wall, or the thumbs into the wall. But before she does this, and you can't see this real well, is she's doing scapular depression and retraction. So she brings the scapula back and down and then pushes back into the wall. Again, another scapula strengthening exercise. There's one in supine, so it's a progression on this exercise. Upright rows would be another option for the upper trap. The lat pull down, we know it's an extensor, so pulling down into extension, oblique, abdominal curl. Supine leg exercises, great for lower abdominals and hip flexors. Increasing the resistance, sideline sit-ups. Don't try this one by yourself. It would be difficult. Bridge progression, so working on the glute max, then going into single leg. Lunges, we had discussion about this on Thursday, and how we can use this as a glute strengthening exercises. And there were several varieties that were demonstrated: forward, sideways, backwards, stationary, progressive. Prone trunk extension. So again, if we have poor extensors, we aren't getting to that mean strength number. When we do this as a test for the core, we might prescribe prone trunk extension. An option would be down here at the bottom too, or holding on to a plate and going into extension. Prone leg lift, this is one that I give a fair amount actually for glute strengthening, and for that then I have them bend their knees and bring their legs just up to parallel, so bringing them from about 90 degrees of hip flexion up into extension, but not beyond that, because that would cause them to engage their low back. And then again, we could go to the quadruped arm raises, working on back extensors. We want them to maintain their pelvis in a neutral position. So starting with just the arms, then doing alternate arms and legs. Sometimes I'll put a stick or a foam roller right across their back, running perpendicular to the spine. The goal being that they have to be stable enough that that doesn't fall over or fall off while they're doing the exercise. Lateral trunk rotation with TheraBand, so the feet are elevated a little bit, and he's pulling into a rotation for the obliques. Resisted leg lifts, another option for core exercises. Pretty difficult exercise to do, as she's pushing the legs away, and he has to bring them back up to her, and she keeps pushing them back down. And then just a few examples of medicine ball exercises if you like to use this type of modality to progress your exercises. So those are the general exercises that we have for the back. On your notes, though, if we look at that, we'll just quickly go over this, that it's kind of a review. Remember, when we're talking about posture and pelvic stabilization, that it should be assessed with anybody that has back pain, and typically we're going to be strengthening the abdominals, glute med and glute max, and the extensors. However, not everybody has to perform these exercises. This is why we do the McGill Core question, assessment, so that we can find out which ones we should prescribe, and then find the appropriate level. Not everybody should start at phase 1. It could be a big waste of time for some people. They'll get bored with the program and then won't be compliant. Remember that pelvic neutral should be maintained throughout. So if you have somebody that's in a severe lordosis, when they come in and you say, okay, let's go on to dead bugs, and you say, let's push your low back into the table or the floor, and I want you to start dead bugs, and they start to experience pain, it might be because their pelvic neutral, their position of most comfort, is not where they reduce their lumbar lordosis. They may have to have a little bit of lumbar lordosis. So you roll up a towel or two, and you just place it in their low back and their spine, and then they can push against that, but it keeps them in a little bit of lordosis. Now, somebody that doesn't have lordosis can easily get into that position where their back is flat against the table. So pelvic neutral, you have to combine a good neutral position between, it's the position that they can go into extreme lordosis and extreme kyphosis or flattening of the low back, and then that position in the middle. So it might be a little different for everybody. Abs should always be contracted when they're doing their exercises. Progressions, I think we've talked plenty about progressions on that. And then as far as a program as a whole, you move into agility, coordination, plyometrics, making sure that pelvic stability is maintained. They should have a little bit of tension on their abdominals to hold them as so that they have a good foundation for the extremities and to work on. So we'll end this lecture, and we'll work on, we'll address special rehab applications in the next PowerPoint.